I tend to describe it very simplistically as your body is basically attacking itself, and specifically your brain. That can happen through many different mechanisms, but usually what happens is that you have an immune response to an antigen, which is just a protein or a factor that is expressed on the inside or outside of your cells, which could be your neurons or other cells in your body. And that stimulates an immune response because your body doesn't recognize it as itself. And then you get a constellation of symptoms that are consistent with autoimmune encephalitis. I was in my towards the end or middle of my third year of medical school, and I contracted a viral illness while on one of my rotations. It took a really long time for me to kind of recover initially, and then even still, I wasn't feeling back to 100% at any point. And I started to, a couple weeks after I started recovering, I started to have these new headaches that I was waking up every day with a headache. So towards the beginning of my fourth year, I started to develop more symptoms of, kind of this emotional lability. I thought maybe it was, as most people did, I thought it was, the rigors of medical school, that I was just burnt out or stressed out about the idea of applying to residency. So I took a month vacation. It was about 8 weeks before I finally made the decision to seek medical care. I was at my parents' lake house, and I looked at my mom and I go, I know this is gonna sound crazy, but I think something is wrong. Like, I'm having trouble keeping my eyes open. I'm having what feels like electrical shocks all through my body. At that point, I went to the emergency department at my local hospital, and exactly as I anticipated, I was told that this was probably related to the stressors of med school, that I was just anxious. I was given a lecture on how I wasn't a failure if I didn't become a surgeon, and they gave me a headache cocktail for migraines for the next probably 3 to 4 months. My running diagnosis was anxious type A female medical student. After that, I went to several neurologists. They did an entire battery of tests on me, still not believing that this was my diagnosis. And then all of those tests, blood work, I did have a lumbar puncture, and they sent my CSF off for analysis for the autoimmune encephalitis panel at Mayo Clinic. I had a host of different scans to look at the blood vessels, both the arteries and the veins in my neck and head, and all of that came back normal. I underwent a PET scan, which my mother and her colleagues ordered as a result of some literature that had been published specifically by John Probasco out of Hopkins. And with my PET scan, it was read as being grossly abnormal. So there were very clear abnormalities. And at that point, my parents made the decision that we were going to all fly to New York City. I was immediately admitted to a hospital, actually the hospital from Brain on Fire, and was diagnosed within about 15 minutes of arriving in the ER with autoimmune encephalitis. The antibody test is used to detect whether there are antibodies in your blood or in the cerebral spinal fluid that would recognize a protein either inside the cell or outside of the cell on a cell that would be seen in the brain, like a neuron. So the test is really important in that if you have a positive antibody and you have, a certain titer of that antibody, it's really important in that sense. As far as antibody testing, is concerned, we've made huge strides. Since 2007, there's been a huge leap in the number of antibodies we've discovered, and then also in the kind of evolution of the test. And so it's very valuable, especially if you're positive. I think it also is very valuable in that clinically the type of antibody that you have could mean different things. It could also mean different things as far as treatment, outcome. So the antibody tests are conducted using a methodology called indirect immunofluorescence. And basically what that means is that you have tissue. In this scenario, it's often mouse tissue of various organs, including like the cerebellum, kidney, intestine, but you basically just have tissue on a slide. When a patient's sample comes in, either serum or CSF, it's incubated or it's put onto the slide where the tissue is mounted, and that if you have an antibody that recognizes a protein expressed in that tissue, what will happen is we will incubate with a secondary antibody that has a fluorescent tag on it, and you can view that under a special type of microscope. So, if you don't have an antibody, so then nothing from your serum or your CSF binds the tissue. When we put on the secondary antibody, which has that fluorescent tag, you won't necessarily see anything. Seronegative basically just means that an antibody hasn't been detected. So that could be for many reasons, whether it's because, of some of the inherent limitations of the antibody tests, whether it's because you don't have a high enough concentration of antibody, or if perhaps your antibody hasn't been discovered yet. Those are reasons why you could be seronegative. When they were looking for my antibody, they also looked for other things like immune cells, and an increased level of those in the spinal fluid. And so that came back negative, and very quickly that was used to say I didn't have this disease. So that's kind of where that started. And I actually, throughout my treatment, didn't ever have an antibody detected, but I did have other clinical findings and then also other diagnostic findings on my cerebral spinal fluid that did suggest there was an inflammatory response occurring. I got steroids in the hospital when I was admitted in New York. I had a massive response to that. It went really well. I slept for the first time, in months. I slept mostly the whole week. And so that was a huge improvement. I was able to start reading again. I was able to kind of see myself heading back towards, my baseline. But steroids are a temporary solution. I was admitted to the hospital for almost 4 weeks, where I underwent plasma exchange, steroid treatment, and tocilizumab. I had a miraculous response to that. I felt the best I had felt in 2 years after my final day of plasma exchange. But again, that's only temporary, right? You take out all of the antibodies from your blood, your body's gonna make more of those if you're not getting rid of the source of the problem. So I started deteriorating again after I returned from New York. My background is in neuroimmunology, so that's where I started looking into plasma cell targeting agents. And I had a ton of experience with these because my background is in both neuroimmunology, but then also cancer. So I called the doctor and the scientist who basically led the development of bortezomib in the clinic. And, he's at Harvard, and he called me at 10:30 at night one night after he was finishing in his clinic and was like, yep, this sounds awesome. So, for me, it was a combination of targeting those B cells, which will give rise to the antibody producing plasma cells and plasmablasts. So we need to get rid of that. And then we need to get rid of the cells that are producing the antibodies. And within a month of starting my treatment, it was like a night and day. And that actually, while I still had to go through this progressive improvement, it was very clear that this time was different. This was different than all of the other treatments. I was progressively getting better. I didn't have as many peaks and valleys. I wasn't needing treatment before my next treatment. My biggest, advice to clinicians is that it's really important to understand what your patient's baseline is. And it's really important to understand what they normally do and to take that seriously and to listen to that. Because I think a huge portion of this is, clinical. For me, it was night and day when I would receive some type of immunomodulatory drug. So not all of those drugs got me back to my baseline, and some of them got me back to my baseline for a short while, but didn't persist. My work is in neurofibromatosis type 1 and type 2. Neurofibromatosis type 1 is my primary focus, and it is one of the most common genetic cancer predisposition syndromes that affects nearly 1 in 3,000 individuals. And so while my work is primarily focused on developing treatments and diagnostics for the detection of benign and then malignant tumors associated with neurofibromatosis, there's also a component of my research that is involved in neurocognitive and kind of neurological areas of research, because patients with neurofibromatosis can also experience ADHD, autism. They also suffer from many psychiatric disorders or behavioral differences. And so when I'm not studying cancer, I'm studying the brain as it's related to those phenotypes in the setting of NF1. This experience has opened up a lot of opportunities for me, both professionally and then personally, in both neurofibromatosis, but then also in autoimmune encephalitis. I always say that I learned more about what it would take to be a great physician at being a patient. My life has kind of fallen into this place where I'm having a lot of success. I love going to work every day. I work with this incredible group of people, and I have a lot of opportunities that I would not have had